Hello and welcome. My name is Felix Maffut. I'm working here at the Saarland University Hospital in Homburg, Germany. And my task now is to update you on catheter-based renal denervation for treatment of hypertension and beyond. These are my potential conflicts of interest. Well, device-based hypertension therapies is a novel and quite innovative field of hypertension treatment. You can see on that slide here a high-level summary of the available approaches that are under clinical investigation currently. We have cardiac neuromodulation that is delivered through a dedicated pacemaker. There are devices out that stimulate the baroreflex and activate the baroreflex. That can be done using a dedicated pacemaker, but also a stent. We have mechanical treatment options, such as the creation of a central iliac arteriovenous coupler, and the device that, or the approach that has undergone most of the clinical research and where most of the clinical data is available for sure is renal denervation. And here we have three technologies available: radiofrequency, renal denervation, ultrasound-based renal denervation, and alcohol-mediated denervation. In all three modalities, the target is the same. Indeed, we are shooting here for the renal sympathetic nerves that are surrounding the renal arteries and that are targeted through heat using radiofrequency, energy, ultrasound, or that are chemically targeted using the infusion of alcohol. And that is what I will discuss with you in the next couple of minutes. Well, you probably all know the ups and downs that we experienced with renal denervation. The first trials were positive, indicating the blood pressure lowering efficacy of renal denervation in patients with severe resistant hypertension. And then the first sham-controlled study was published, Simplicity HDN3, where denervation was associated with a fall in blood pressure, but also sham treatment, and the difference between the two was not meeting the expected primary endpoint. And this study was negative on the efficacy outcome and positive on the safety outcome. So the procedure was considered to be safe, but not very efficacious. And then there were a couple of options. One was, of course, to let renal denervation rest in peace, or the other option, to deep dive into the experience we made with Simplicity HDN3 to understand what the problem with the device or what potential confounding factors were, and to design a couple of new studies. And the first question was, can renal denervation lower blood pressure? And here we used the analogy to investigate renal denervation as we would investigate a novel drug compound to lower blood pressure. So we started investigating renal denervation in patients who were not receiving any concomitant antihypertensive medication. And we designed the Spiral HDN off-med trial and the Radiant Solo study. The two catheters are shown here, radiofrequency and ultrasound-based. And we looked here for the first time into the blood pressure lowering efficacy and the safety of renal denervation in low-risk patients with moderate hypertension who were not treated with any concomitant antihypertensive medication. So they were either drug naive or have safely been washed out. And a couple of months ago, we were able to publish the first pivotal trial in that patient population. 331 patients were randomized to receive either renal denervation 166 or sham control 165. Primary endpoint was at 3 months, where we obtained an ambulatory blood pressure monitoring. And as you can see, of course, besides efficacy, we were looking into safety, and the results are shown here. An excellent safety profile of the procedure, which is of particular interest in such a low-risk hypertensive patient population. So for sure, you don't want to enhance the risk of patients that were treated with renal denervation. And here, as you can see, only one major adverse event that occurred in the renal denervation group, an early hospitalization for hypertensive crisis, and there was one new stroke in the sham-treated patient. The Efficacy endpoints are shown here. The trial was powered for both office and ambulatory blood pressure. On the right-hand side, you can see office. On the left-hand side, you can see the ambulatory blood pressure falls. As said, in previous sham-controlled studies, we have seen a large fall in patients that were treated with sham. That was not the case in this study here, and this is very pleasant to appreciate from a clinical trials perspective, because in these studies, when you address for the confounding factors, you can eliminate the sham effect of an invasive procedure on blood pressure as shown here. So no effect in sham-treated patients on systolic and diastolic 24-hour, but also on office systolic and diastolic blood pressure. And in patients treated with renal denervation, there was a larger fall in blood pressure, as shown here for both, again, 24-hour blood pressure readings, but also for office systolic and diastolic blood pressure. And the margins were within the expected range, so the study was indeed powered and showed and proved the effectiveness of renal denervation in lowering blood pressure in patients not treated with any concomitant medication. Beside the changes in office and 24-hour blood pressure, we also looked into the hour-by-hour blood pressure. So the concept here is when you lower blood pressure using a device, when you lower sympathetic activity in a patient, what happens throughout the day and night of these patients. And we did a dedicated analysis where we looked into the hour-by-hour blood pressure at baseline for renal denervation, left-hand side, sham control, right-hand side, and at follow-up. And there was a significant reduction in patients treated with renal denervation, and the curves are superimposed for sham-treated patients, so no significant difference. And particularly the nighttime blood pressure and the early morning blood pressure were reduced. These blood pressures are associated with risk of stroke. So hopefully these beneficial effects on the 24-hour systolic blood pressure profile will translate into improved outcomes, and it appears to be always on the effect of renal denervation, unlike the blood pressure lowering effect of antihypertensive medications, where you have peak and trough effects of the substances. Another powered study was the ultrasound device, which is shown here, a balloon-based approach that also lower blood pressure at 2 months, significantly more pronounced in patients treated with renal denervation when compared to sham. So the second trial, positive. And from a perspective, from a clinical perspective, probably this study is also very important because in only a minority of patients, this invasive approach will in the future be used in patients who are drug naive or who do not receive medication. And the vast majority, we assume that these technologies will be used in patients who are treated but are uncontrolled. So the Spiral HTN OnMed trial is quite important because it investigated the effect of renal denervation in patients who received a medication, 1, 2, or 3 commonly used antihypertensive drugs. And we performed toxicological analysis to ensure that the patients really adhered to the prescribed medication, that they adhered to the protocol, and that there were no changes in drug treatment in these patients, at least changes that we couldn't adjust for. And the trial, as shown here, was positive, again, for renal denervation, a significantly larger fall at 6 months compared to sham treatment. So in summary, we do have now 3 independent randomized sham-controlled trials that are completed. The first pivotal study is completed in patients with and without concomitant medication for 2 of these devices that are shown here, radiofrequency and ultrasound. A couple of other pivotal trials are underway. In part, they are completed, such as the Radiance HTN Trio trial, where patients on a triple fixed combination will undergo renal denervation or sham. This trial has completed enrollment and will hopefully be published early next year. Require Pivotal is a study where patients on 3 or more drugs are investigated. Spiral OnMed is the extension of the a spiral unmet pilot study, and Radiance 2 is the extension of the Radiance solo study. So more and more data aggregating that will hopefully confirm the blood pressure lowering efficacy of these devices. As introduced at the beginning, new modalities are also around the corner and are also investigated. One promising one is alcohol-mediated renal denervation, because that comes without a generator. What you do here is you use a microcatheter that injects pure alcohol around the renal arteries. This pure alcohol spreads circumferentially and is a neurolytic agent that then ablates these nerves and the nerve activity. The first sham-controlled study is ongoing. What we published very recently was the first in men trial, where in this open label registry, where we use toxicological analysis and also ambulatory blood pressure, so gold standard methodology, where we confirmed the blood pressure lowering in 24-hour blood pressure, systolic and diastolic, and also in office systolic and diastolic at 6 months. So quite promising. As said, the first hurdle taken, and now this device is undergoing a quite rigorous investigation in a sham-controlled study, and I hope we will see these results also published next year. These sham-controlled trials are selecting patients that are to some extent arbitrary. So from a clinical perspective, it is important to look into real-world patients with uncontrolled hypertension. And here, the Global Simplicity Registry is a unique database that provides a lot of insights into these patients and into the effectiveness, but also, and most importantly, into the safety of renal denervation when treated in countries around the world. As you can see, almost all geographies participate in that endeavor, and up to date, we have close to 3,000 patients enrolled in that registry. And the registry follows these patients for 3 years. So it's also enables us to look into the sustained effectiveness of renal denervation. And as you can see here, for patients who completed their 3-year follow-up in the registry, there was a sustained fall in blood pressure in both office and in 24-hour blood pressure. So indeed, no indication of a secondary rise in blood pressure in these patients treated in the registry. Of course, with all the limitations that a registry has, open label, lost to follow-up, but this provides the opportunity to look into long-term effects of this treatment. And we also looked into various subgroups of patients with different comorbidities, but also with different baseline cardiovascular risk. And we just published a paper in JACC on subgroups with elevated cardiovascular risk, such as elderly patients with atrial fibrillation, high cardiovascular risk assessed using the ASCVD risk score, patients with diabetes, with resistant hypertension, and isolated systolic hypertension. So really those patients where we fear the consequences of an elevation in blood pressure treated with renal denervation, and here we documented favorable safety profiles of the technology. This was radiofrequency renal denervation, but also blood pressuring across the subgroups. Where's that field moving to? And this is one of my last slides. I think it is important, and it will be quite interesting to see how this is evolving in the near future when renal denervation is used in patients not for the indication of hypertension, but for the indication of neuromodulation. And one trial that has been published in JAMA points into that direction. Has some limitations, as all of these studies do have, but it points into the direction of investigating neuromodulation for different indications or indications beyond hypertension. Indeed, the Eradicate AF trial investigated the combination of pulmonary vein isolation with renal denervation and compared that to pulmonary vein isolation alone in patients with paroxysmal atrial fibrillation. And there was a relative risk reduction of more than 40% in patients treated with that combined approach of pulmonary vein isolation in combination with renal denervation. So quite promising, more data needed for sure. We're also investigating this now in patients with chronic kidney disease, in patients with heart failure, in patients with ventricular arrhythmia. So hypertension may just be the beginning of the investigation. So what is next? And this slide here summarizes all the available device-based treatment options of renal denervation and where we are moving to and what are the unmet needs. A big part here is related to patient-reported outcome and shared decision-making. So patients have to be involved in the process of which approach to use to lower their blood pressure. Lifestyle modification is, of course, established. Antihypertensive medication is established to lower blood pressure. And now we're creating a third pillar, which is device-based hypertension therapies, indeed, renal denervation. And then in the future, we will have to combine these pillars of effective antihypertensive treatment smartly and according to patient preferences. We need to identify predictors of response for sure. We need to assess long-term safety and durability and the outcome of the blood pressure lowering on hypertension-mediated organ damage and prognosis, cardiovascular morbidity and mortality. We need independent real-world registries in all these indications. And as said, we're looking beyond hypertension, heart failure, arrhythmia, CKD, metabolic syndrome. Very interesting and definitely more to come. With that, I thank you very much for your attention and I hope you enjoy the conference. Thank you.